the individualized approach to sleep hygiene. And these are my learning outcomes for today. Um, Sleep hygiene is actually a very utilized and often utilized way of advising our patients. You might see them everywhere. So this could be in social media platforms. Um, a lot of people are talking about it in the social media and also promotional materials in the internet. Uh, and I'm sure it is um, often advised to a lot of patients who would complain of difficulty sleeping. They said sleep hygiene is a prevention. So it has not been established as a cure, but a way to prevent difficulty in sleeping for those who are predisposed to insomnia. Dr. Howry was the first one who actually formulated the sleep hygiene rules. As you can see, this is like a pamphlet that you should follow. You can give your patients, and it is 10 item. And it has gone through a lot of revisions. Okay? So he also made a revision himself. And what is consistent throughout the revision was to avoid coffee. Okay, but I'll explain later what each of these um if there are any evidences or research that says all of these behavioral changes are actually effective. All right. So the first one is don't drink coffee 6 to 8 hours before bedtime. So we hear this a lot. And I know Vietnam is a coffee drinker, a country that often drinks coffee. I'm not sure if you drink it at night, but we hear our doctor saying, do not drink coffee 6 hours, 6 to 8 hours before bedtime. Okay. Oh, those. Okay. So as we know, coffee is a stimulant. It blocks the adenosine in the basal forebrain and the hypothalamus. It is said that after 30 minutes of taking coffee, it peaks in their plasma levels. The half-life is around 3 to 7 hours, but it differs among individuals. So this is based on your sensitivity to caffeine, your metabolism, and the accumulation of caffeine in your system. So they did a study to challenge this advice. If you cannot drink coffee before bedtime, so what they did is they administer 400 milligrams of coffee, and they saw disturbances on both subjective and objective sleep. Another study did administer 600 milligrams of coffee. That's equivalent to 5 to 6 cups of coffee 30 minutes before bedtime. And they saw that the sleep onset latency, there is an increase and there is a decrease in total sleep time and your sleep efficiency. Another study administered 300 milligrams of caffeine before bedtime, and they saw significant impairments. So I ask everyone, do you drink 5 to 6 cups of coffee before bedtime? I don't think so, right? So there is less supporting data that shows low to moderate amounts of intake of coffee will actually affect your sleep. They also tested caffeinated versus decaf among after dinner among patients who are said to be caffeine sensitive. And they saw that caffeinated beverages had significant effects on sleep. But they really chose the subjects who were very sensitive to caffeine. If you are caffeine naive and you drink coffee before bedtime, on night one, you will experience fragmented sleep, poor reported sleep quality, and lower sleep efficiency. But on night two, there are only changes in the actigraphy, but the subjective feeling of the patient is actually back to its normal state. And they said that we also develop tolerance to caffeine. For those who are regular users, they were given 150 milligrams of coffee, and they saw that there is a difficulty falling asleep and lower sleep quality, and 45 minutes less total sleep time on actigraphy. But when you are taking only 75 milligrams, there's still an effect. 15 minutes less total sleep time on actigraphy. But we know regular caffeine users do not complain about their sleep. That's why they drink coffee. So if we tell our patients, do not drink. So we tell them, abstain from taking your coffee. They saw that fewer problems falling asleep on days without caffeine. So they also challenge, what if you drink coffee for 6 days and then skip one day? They gave the subject a placebo. They saw that there was a longer sleep duration compared to the abstinence. So meaning sleep was actually longer for those who drank their coffee regularly or as is. Caffeine cessation by habitual users is not very effective at improving sleep. Perhaps because tolerance has developed to caffeine's sleep disrupting effects. So, if your patient is a regular caffeine drinker, then telling them to stop will not actually benefit them. So, in summary, caffeine administration close to bedtime disrupts your sleep. That is correct. But effects of the caffeine on sleep show a dose-response relationship. So, very high doses of caffeine. The fact of morning and afternoon caffeine use is less clear, and harmful effects of caffeine on sleep may be limited to caffeine-sensitive individuals. So these are those individuals when they drink coffee in the morning, sleep is still affected at night. Those with palpitations, physical symptoms of caffeine. Tolerance to caffeine's effects on sleep develop within days. So once you get used to the caffeine in your system, you actually lose the negative effects on sleep. Here's another sleep hygiene advice. Do not smoke before going to sleep because nicotine is still a stimulant. It's still there's stimulation of the cholinergic neurons in the basal forebrain. There's also said that there is an increase in sleep onset latency, decrease in total sleep time, more frequent early morning awakening, and the suppression of REM and your slow wave sleep. So we tell our patients, don't smoke before bedtime. Nicotine withdrawal actually causes heightened arousal and cravings. And this would peak few days to 3 to 4 weeks. So now, because of the increase in your arousals, in the frequency and duration of your arousals, your patient would again go back to smoking. So non-smokers versus former smokers versus current smokers. So they made this study and they found out that former smokers and non-smokers did not differ in sleep. Sleep impairments associated with smoking may be resolved after cessation, and long-term sleep improvements can be achieved following smoking cessation if they are monitored and advised by a physician. So we know smoking cessation does not it's not as easy as telling them stop smoking. They saw that there is no tolerance to nicotine sleep disrupting effects. Even after years of smoking, smokers experience significant worse sleep than non-smokers. And this could be due to the other chemicals in the cigarette as well. How about those individuals who are occasional smokers or those who experience secondhand smoking? They saw that there is REM suppression and early awakening, and they would experience REM rebound and normalization of your wake time on recovery night. So the night after, they will just recover back to their usual sleep habits. So in summary, acute and chronic nicotine administration or smoking disrupts your sleep, but arousal increases temporarily during acute nicotine withdrawal. That's why you should be assisted by a doctor when you're doing this. And few limited studies suggest sleep problems associated with smoking can be resolved after cessation and withdrawal because the effect of your nicotine can persist even after years of cessation. This one, avoid alcohol at night. So there are some cultures who would actually drink wine for dinner. Okay, let's see if this is actually true. So they saw that if you drink your alcohol near bedtime, there is decrease in sleep onset latency. So you immediately fall asleep. And there is an increase in slow wave sleep during the first part of the night. So imagine your night is always divided into three. So your first part of the night, that is faster to fall asleep and deeper sleep. But once you metabolize your alcohol, it now increases your N1 and REM sleep. And you will experience more arousal. So this could lead to also nocturia. So you would frequent the toilet. So for those who had some alcohol last night, so maybe you can compare your sleep to this. So they also saw that women's blood alcohol levels are significantly higher than men's after consuming the same amount and type of alcohol. So you tell them, stop drinking your alcohol. So they saw that dependent users has long-term alcohol abstinence may result to modest sleep improvement because your sleep problem may still persist even if you stop taking your alcohol. This is short sleep duration, lighter sleep, and greater sleep fragmentation. So you see this a lot in your addiction units, individuals who would undergo detox, even if they're free from the alcohol, they would still complain of sleep. And the same with your nicotine, relapse is very high. Do you develop tolerance to alcohol? So for non-dependent individuals, tolerance to sleep disrupting effects occurs within days, even with high doses. But for those who are dependent, there is chronic sleep disturbance. And this result in lasting alterations to key physiological systems which contribute to sleep regulation. So they tried to challenge alcohol. So they gave it to individuals 6 hours before bedtime. And PSG were similar to those found with bedtime administration. So some would say, oh, maybe you take the alcohol late afternoon. But still, the same effect is seen in the PSG when they sleep. Higher doses of alcohol are associated with worse sleep, and that is when somebody intakes around 3 standard drinks. And occasional and light consumption may be less likely to disrupt your sleep. So I guess a shot of wine or a glass of wine will not affect the sleep. So in summary, acute alcohol administration before bed decreases your sleep onset latency but increases arousal during second half of night. The effects of alcohol on sleep are dose dependent. Tolerance to alcohol's effects on sleep occurs within days. Sleep problems increase during acute withdrawal of dependent users, and despite modest improvement, long-term sleep problems persist in abstinent former users. Okay, so the next sleep hygiene advice is exercise in the morning actually deepens sleep at night. Exercise may improve sleep through its effects on body temperature, your arousal, and adenosine levels. So among young adults without sleep problems, they were asked to do exercises, and it was seen that there is an increase in the PSG total sleep time, your NREM stage 2 sleep, your slow wave sleep, and latency to REM sleep, as well as a small reduction in your sleep onset latency. For those with insomnia, there is an acute bout of moderate intensity aerobic exercise performed in the late afternoon, substantially improve PSG, and diary assess sleep onset latency and total sleep time on subsequent nights. So I usually tell my patients the best time to exercise is late in the afternoon, around 4 to 6 p.m., which can advance your sleep for around 20 minutes. 60 minutes exercise training, if you do it for more than 4 weeks, there was a large increase in your total sleep time. There is no specific mode of exercise that actually showed a good effect on sleep. Exercising close to bedtime may actually improve sleep due to the acute body heating, anxiolytic, and antidepressant effects of exercise. So there are two advices. So we usually tell our patients do not exercise before bedtime. But once you see a pattern and they would tell you they actually sleep faster when they exercise before bedtime, then you allow them to do so. Okay, so as I said earlier, 4 to 8 hours prior to bedtime, decrease your PSG assessed sleep onset latency and WASO. Nighttime exercise does not support the claim that late night exercise disrupts sleep in the general population. So especially for those young adults who would have worked the whole day and then they only have time to go to the gym in the afternoon or be with friends, playing volleyball, tennis, basketball, some of them will actually fall asleep faster versus on days that they don't exercise. And that could be due to the body temperature, the heating of the body. So in summary, regular or acute bouts of exercise produce modest improvement in sleep for individuals with and without sleep complaints. Current evidence does not support the claim that late night exercise disrupts sleep. So it's okay if they exercise at night. Okay, so the next is write down all your worries before going to bed. I don't know if you're one of these wherein when you go to bed, you think of your grocery list or or you think of what am I going to do tomorrow? So they said, write it down before you go to bed. Because stress is actually an event or events that lead to acute or chronic physiological and psychological responses. So these are what we call cognitive and physiological arousal. So they disruption to sleep initiation and maintenance. You ruminate before bedtime, and there's an acute anticipatory stress where there is an increase in your sympathetic arousal, wakefulness throughout the night, and less restorative sleep. Acute psychosocial stress on sleep may resolve when the stressor is resolved. But for most of our stressors, it doesn't get resolved overnight. And these individuals are those individuals who are sensitive to stress will actually experience more arousals and more sleep stage transition. So I think that was my lecture yesterday. And challenging without clinical guidance. No, sometimes you just tell your patients, okay, relax before going to sleep. What if it's not appropriate to their needs? Some culture will actually differ. For example, there are Hindus who does their chanting, which is a form of meditation. They do it while lying down, and then they will chant, and then they will feel relaxed. So that's actually against the sleep hygiene because you're advised not to do that in bed. But if it relaxes them, then that's appropriate. You allow that. But there are also individuals who cannot meditate. I'm not sure if you try to meditate, you become bored or you will have intrusive thoughts. So if that's the case, then meditation is not okay for you. An example is the mindfulness. So this is a relaxation not directly responsible for better sleep, but actually relaxation is focused on attention that is incompatible to cognitive arousal. So what is mindfulness? This is focused attention on the present without judgment. A very simple way to say is, when you drink coffee in the morning during breakfast, do you think of the traffic? Do you think of how can I get from my place to the office? Or do you think of how tasty the coffee is? Because if you notice how tasty and hot your coffee is, then you're being mindful. You're being present in that situation. And they said that it improves subjective sleep quality. There's reduction of perceived stress and reduced pre-sleep arousal and worry in individuals with insomnia. So in summary, psychosocial stress is associated with increased pre-sleep arousal and impaired sleep. Various stress management strategies have been shown to reduce pre-sleep arousal and improve sleep, and individual differences influence perception of stress and coping style. The bedroom should be quiet. I think this was emphasized by Dr. Tuazon that the snoring actually affects our sleep. Nocturnal noises within one's normal surrounding actually increases your number of arousals. Increase N1 and N2. They suppress slow wave sleep and REM sleep. But they said you get used to it within days. So if your house is beside the main street, after a few days you'll get used to the cars every night. It becomes a white noise. This is moderated by characteristics of noise. So the continuity, the type, the relevance, and the individual's noise sensitivity. You can modify noise by using sound reducing earplugs and white noise, your sound masking. White noise is your fan, the sound of your fan, the sound of your air conditioner. That's the white noise. It reduces sleep onset latency, it increases slow wave sleep, and improves subjective sleep quality. So nighttime noise increases arousals. Habituation to noises occurs, but your EEG arousal may persist. And specific noise reduction strategies have been shown to improve sleep in some environments. So this is part of sleep hygiene and your sleep restriction. It is said that you maintain a regular bedtime and rise time. To maximize synchrony between physiological sleep drive, circadian rhythms, and nocturnal sleep episode. Sleep is worse when there is dysynchrony between sleep-wake timing and other endogenous circadian rhythms. So for those who are advanced and delayed, and you sleep against your own circadian rhythm, it can worsen your sleep at night. And also those with inter-night variability in sleep timing, those who do not follow a specific schedule, will actually lead to insomnia. And your CBT targets regularity in wake time, but permit variability in bedtime. So when I advise my patient, I do not focus on the bedtime. I always focus on the rise time because it is the only thing that you can control. When to get up, but you can never control when to sleep. You cannot tell your brain it's time to sleep. It will tell you that you're sleepy, but you can tell your brain and you can ask yourself to get up at a very specific time every day. So when you give a regular sleep timing schedule for your patient, focus on the rise time. Irregular sleep schedules are associated with greater daytime sleepiness and worse self-reported sleep quality. So we're not only focusing on the regular sleep timing, but the regularity of your routine every day, your lifestyle. So it is said that subjects with irregular sleep schedule, they have fixed sleep schedule resulted in increased self-reported awakenings, but no significant changes in the PSG assessed sleep. In summary, clinical sleep treatments encourage regularity only in wake time, which is counter to some sleep hygiene recommendations to adopt regular bed and wake times. Irregular sleep schedules have been associated with poor sleep, but assigning regular sleep schedules to non-clinical adults also shown limited effects on sleep improvement. Okay, avoid napping during the day. No, there's no association between daytime napping and nocturnal sleep based on self-report, actigraphy, and your PSG. But among older adults, daytime napping of more than 30 minutes is associated with more self-reported sleep problems, greater actigraphy assessed WASO, fragmentation, and lower sleep efficiency. Those who are healthy adults with evening naps. So maybe after work, you go home, you feel so tired, and you take a nap. Or on the way home, you're in the train or the bus, you fall asleep. This can cause change in your total sleep time, your sleep efficiency, your slow wave sleep, your REM latency, and self-reported sleep onset latency. But studies are not consistent and inconclusive. Power nap, this is a 30-minute nap. This is beneficial to cognitive performance, alertness, and mood. So those sleep technicians who are feeling very sleepy at night, that you cannot score your studies anymore, it's okay to take a nap. Evening naps in postmenopausal women have shown that there is earlier wake times and more daytime napping. There's also higher actigraphy assessed sleep efficiency and lower WASO as non-evening nappers. Those patients who are habitual and naturalistic nappers, evening nap negatively impact PSG assessed sleep. For those who are older adult, evening nappers, there's short sleep onset latency, earlier wake times, and earlier circadian phase. So when you see your grandma feeling very sleepy at 6 a.m., at 6 p.m., you just allow them to sleep, but be mindful that they wake up at 12 midnight. Young adults with afternoon naps has shown no difference with non-nappers. So if you're a habitual napper, it will not affect your sleep at night if you nap in the afternoon. That's if you are used to napping every day. In summary, most research suggests that daytime naps do not have a substantial impact on subjective and objective nocturnal sleep, despite sleep hygiene recommendations to avoid naps. Nap duration and timing seem to have limited effects on the relationship between napping and nocturnal sleep. Okay, take a warm bath before sleeping. Passive body heating happens when we take a bath. Heating of the body and or brain temperature prior to sleep through hot baths. Increased depth of subsequent sleep, both in normal sleepers and older insomniacs. It increases distal temperature relative to decreasing core body temperature, which is associated with faster sleep onset. And it has a steeper downward slope of core body temperature, which is beneficial to sleep promotion. And this is what's happening when you also exercise at night. Okay, so those are just the common sleep hygiene techniques that we advise our patient. But they said sleep hygiene is not has not been tested adequately as a standalone treatment in insomniacs. A lot of doctors or a lot of people would utilize this because it has a low resource treatment. Is it necessary? but it is not sufficient. It's insufficient. And it also causes delay in the effective treatment of your insomnia. It has lack of efficacy, affect perception of therapies. They also saw that good sleepers and bad sleepers has no difference in their sleep hygiene practices. Actually, bad sleepers had better sleep hygiene practices than your good sleepers. Is sleep hygiene the same for everyone? Ideal sleep hygiene vary per person. When we instruct our patients, we just tell them just choose three out of all the things that you've read and you've heard. Just choose three behavioral change at a time. And the expectation is improving your sleep hygiene would always resolve your sleeping problem. Based on this recommendation, sleep hygiene may be included in your multi-component interventions, but allocation of resources for sleep hygiene alone might divert resources and delay the use of other single or multi-component behavioral interventions that are more effective. So it actually delays the treatment needed by your patient. So in summary, sleep hygiene should be individualized. You really have to know your patient's sleep hygiene behavior or sleep behaviors before you give them the advice. The goal for CBT insomnia is the acceptance of your own circadian rhythm. So when you tell them to have a regular sleep schedule, you cannot tell them to go to bed at 10 and wake up at 6 because we have different circadian rhythms. And sleep hygiene has to be combined with the other components of your CBTI because it cannot be a standalone treatment. Thank you.